Welcome, everyone. I'm Sukin Shah from Wilmington, Delaware. And on behalf of Setting Scoliosis Straight and the Harm Study Group, I'm pleased to welcome you to tonight's Surgeon Education webinar, which involves the intersection or impact of new technology advances in research on selective thoracic fusion. And I'm pleased to be joined today by an excellent moderator, Stephen Wong from the Philadelphia Shriners Hospital, who will be co-moderating the moderating duties with me. But first, a little bit about our foundation. Our mission is to better discoveries and advanced techniques in the treatment of scoliosis in children and adolescents worldwide. And we envision a future in which children will have the ability to live healthy, happy, and productive lives. Today, we'll be discussing the intersection of technology and machines and innovation and man to foster the study and exchange of information. It's only through progress and exchange of this information that we can become better. We'll be discussing the role of fusion, controversial aspects of VBT, motion preservation, selective fusion techniques, preservation of motion in the lumbar spine, and pushing the envelope on both fusion and vertebral body techniques. And our speakers, which are luminaries in this field, include Peter Newton from Rady Children's Hospital in San Diego, Firoz Miyanji from British Columbia Children's Hospital in Vancouver, and Amer Samdani, also from the Philadelphia Shriners Hospital. We have some brief instructions. First of all, the panel and moderators are available to answer your questions live through the Q&A section. Please don't submit your questions through the chat, but rather use the Q&A where we can answer some of them live during the webinar and definitely through the chat as well. So we'll start off with our first speaker, Dr. Peter Newton, who'll tell us about pushing the limits of selective fusion. Peter?
Great, thanks so much, Sukin. Well, here are my disclosures. I've got many, some relate to posterior fusion, some relate to tethering. The topic really here is selective thoracic fusion, and of course the goal is saving lumbar motion segments. And to provide I'm going to emphasize three-dimensional instrumented correction of the thoracic curve, and then hope and expect and somehow be able to predict spontaneous correction of the lumbar curve for a patient, as you see on the right. The long-term outcomes of this, I think if we get good correction, that lumbar spine is durable, but you can see in this case, at 9 and 20 years, there's been some progression of that lumbar curve over time. And I think we're hoping that we can get even better initial correction. I was happy with this when I did it 20 years ago, but as I look at it now, I wish I'd gotten more correction initially in the thoracic and in the lumbar spine. I think it's clear if we do look at some of these long-term cases, though, that there is some improvement over time spontaneously. That initial leftward decompensation improves over time. And if we can get that spine really straight in the thoracic region, we can induce that lumbar spine to be equally straight in the coronal plane. And in creating kyphosis allows lumbar lordosis to follow underneath, also a very important component to three-dimensional correction. I'd like to just make sure we're talking the same terms. I think most of the people on this webinar are going to be familiar by the stable vertebra, the one most closely bisected by the center sacrovertical line, and the neutral vertebra, the one that is least rotated in the axial plane. The spinous process projects between the pedicles. I do think those are important landmarks as we talk about the axial plane and coronal balance. Many times that's the same vertebra. In this case, T11 is stable and neutral. But sometimes they're quite far apart from each other, and we really can focus on those two levels separately. I think one important point that I'd like to make and emphasize in this talk is the axial plane deformity that exists. And I think we often think about the point of maximum axial plane deformity being at the apex, but the maximum intersegmental deformity in the axial plane is around the neutral vertebra between the curves. So this is the area where if you really want to do derotation, that's where we should do it, is where that deformity of rotation is greatest. So our goals are clear. We want to limit the extent of fusion and maximize that lumbar curve response. The question is, how do we accomplish that? Well, again, I'm going to circle the area that I think has become a more critical area of focus for me of late. I've always pushed to get maximal correction of the coronal. And I know that is contrary to what some believe. They want to shoot for balance, but I'll tell you what, balanced but straight is better than balanced but still curved. The sagittal plane to restore the kyphosis. But in that yellow circle is where we need to derotate around the neutral vertebra. And I'm gone below the stable vertebra and below the neutral vertebra to grab another vertebra to really initiate correction in the lumbar spine only partially spontaneously. I grabbed the top of the lumbar vertebra and put it back underneath where I thought it should go. And I think that's a really important component to selective thoracic fusion, maximizing spontaneous lumbar curve correction. So I'm going to say go longer than the stable vertebra, stable +1. An axial correction above and below the neutral vertebra. That means you need to instrument below the neutral vertebra. And again, it may just be one, but it's enough. And really do what you can to create kyphosis. When we derotate, we tend to bring that lordotic thoracic spine into the coronal, into the sagittal plane and re-demonstrate that loss of kyphosis that we know is there. But working hard to add posterior column length, I think, is really important as well. Let me take you through a couple of examples. Here's stable vertebra T11. I just told you I thought we were gonna go 1+. Let's see if I did. Very flexible lumbar curve, good candidate for a selective thoracic fusion. And in a case like this, one below stable, one below neutral, even if you don't get all the pedicles in that bottom vertebra, or the screws in that bottom vertebra, I think I missed one on the right there, you can still get very good correction in that spontaneous correction of the lumbar spine. Let's look at another one. Big lordosis here. So we've got a huge job to create kyphosis as well. Very high PI. So high PI, big lordotic spine. We got a lot of work in the sagittal plane to do for this. So how low to go? Patients decompensated to the left. So stable +1 is probably not enough because stable is way up there at T10. So we'll go based on the end vertebra here and say it's got to be N+1. Now we're back to something like 12. We're getting close to the apex. Might be getting you nervous there. But here's where we went, all the way down to 1. Holy smokes, really to the apex. And off to the left, nervous, worried, but the kyphosis was there. We did a good job there. And you can see after 6 months, that has really come back and rebalanced nicely. So to get that much kyphosis is a big job. And I think that's part of the reason to go so low as well, to get enough leverage at that bottom to really create that kyphosis. I know that makes you nervous going to the apex. I get it. And I've been burned doing that as well. But that was a good example of where it's a win. Pay attention to the sagittal stable vertebra in your selective thoracic fusions as well. So here we got stable sagittal at L1. Again, is that going to push you down to L1, or are you going to be happy just going to 12? I pushed this one down and looked pretty good supine, but at 6 months, this has not come back around. I'm going to give it some more time and keep my fingers crossed, but I'm pretty nervous about this. So I think you do have to be cautious about this extending long towards the apex, whether it's due to the sagittal stable vertebra driving you down or just the curve itself. So I can't tell you this is a perfect panacea, and be careful going too below stable. But I do think it makes sense to go for maximal coronal correction. I really do think that's what gets you the best spontaneous correction. Maximize the kyphosis, derotate above and below neutral, and consider the sagittal stable vertebra in choosing your LIV as well to avoid distal junctional kyphosis. I think that's a risk for these patients as well. So sometimes selective thoracic works in VBT and sometimes it doesn't. The rest of the guys are going to talk you to more about this, but should that work well? Yeah, it does sometimes. Sometimes it doesn't. And again, in these bigger lumbar curves, this idea of a hybrid construct is something that I endorse as well, and you'll hear more about that in the coming talks. So I hope that gets us started. Here's a case to leave you with. Big thoracic, and that zone to derotate around, anterior releases in this case as well, and make it straight, and that lumbar spine will come right around. So I've emphasized these points over and over. Here's the to get a better selective thoracic fusion, you got to get into the lumbar spine a little bit, at least neutral +1 and often stable +1. Do that derotation around that. Really focus on segmental derotation above and below the neutral vertebra. I think that is a really powerful tool. So here's a last example to take it. Should we, again, put that tether in there, or should we just do this as a selective on your own? I think that's another area for us to debate extensively. And when do we need to add this tether, and when can we do it just with a selective thoracic fusion? But you can see I can get even longer to the apex when I know I'm putting a tether in, and that gives me a little more confidence we won't have that trouble. Anyway, I do think we've got some questions remaining, and which of these will do well, and can smarter folks tether both curves? And are there some immature 3C and 6Cs that you should consider a hybrid? We'll get the rest of the talks to answer those questions. Thanks, Sukan.
Thank you, Peter. And we're already getting questions coming into the Q&A section. But to get things started off, I'm glad you summarized your rules. So definitely neutral +1, often stable +1. Get into that lumbar curve a bit, emphasizing sagittal plane reconstruction. But tell us again, if you can, what your sequence of derotation is, because I think a lot of people have questions about that. Conceptually, without coming to your operating room, it's been hard to articulate or teach that. But what pointers can you give us about that?
Yeah, it's a great point. And I think, as we all know, if there's 100 surgeons doing scoliosis surgery, there's 100 ways to do it. My preferred method is a very over-contoured concave rod, put in first, and locked into position at the neutral vertebra. Second rod goes in, under-contoured, put in the proper sagittal alignment, locked at the neutral vertebra. So the only place those rods are initially locked is at the neutral vertebra. And then I derotate below it and lock that vertebra to try to really push that lumbar curve around back underneath. And then I go back and segmentally derotate above the neutral vertebra, pretty much up to the apex, a touch beyond, just to make sure that I get everything as straight and as much as possible, those screws all pointing straight ahead. And I'll go back and do a second round down below to try to really push that lumbar spine over as well. But it's a combination of rod contour and segmental derotation around the neutral vertebra.
And Blake's got a question about optimal restoration of TK. How do you get there?
A liberal use of pontiostiotomies and again, it doesn't have to be a pontiostiotomy that resects bone, but it has to be a pontiostiotomy that cuts through the supraarticular process and sections the ligament of flavum, that allows the posterior column to be lengthened, and a very aggressive bend in the rod. And if you're going to do that, you need really good fixation to pull those screws towards the ceiling. And if you got little tiny screws and bad bone, you'll rip all the screws out, of course. And so trying to judge how much force you can apply based on your fixation's an important variable. But I use 6.0 titanium as my preferred rod. I like the elasticity of that rod. I can put a very large bend in it and have it be springing back up into that position after it flattens during insertion, so that when I do my derotation, that rod is helping me get my kyphosis back during derotation. And derotation is trying to take kyphosis away. I mean, we're trying to roll that lordotic spine back into kyphosis. So those two things are hard to get together, but important to work the rod shape, the rod material, the rod diameter, and the releases to get what you need. And occasionally I still add an anterior release, as you saw in that last case.
That was 25 plus years of wisdom in about 2 minutes. So one last question before we move on, because a lot of us want to know, if you got burned with, say, a handful of cases along the years, can you point to any preventable things that you may have missed checking for, or that you wish you could have had a redo on? That is failed STF. Yeah,
it's a great question. I mean, I think sometimes I think early I missed the lateral I didn't get enough kyphosis in the lateral. I missed the sagittal stable vertebra for, many, many years of my career and had distal junctional problems. And I just was, I've been nervous about going below stable for a long time. And then when I started to push that limit, I realized how valuable that extra vertebra was. And as long as I could, manhandle it and get it back underneath, I've done really well. Going longer than one below is really pushing it, and I've done that some. And again, I feel much more confident when I know I'm going to drop a tether on that lumbar curve as well, because it kind of protects me. But that has given me confidence to see what I can do, even going two below. And I mean, as crazy as it sounds, I've actually done some selective thoracic fusions now on lumbar major curves, which seems completely ridiculous. But I'm not advocating any of that. Okay, I'm just unless you want to try to get burned like me.
Excellent, Peter. Thank you so much. Harvey, we'll need to move on, and we'll introduce our second speaker, Firoz Miyanji. And he's going to tell us how VBT has impacted indications for STF. And so with innovation comes studying sometimes the classic techniques, and Firoz will tell us what he's learned along the VBT journey.
Thanks, Sukin. Thanks, everybody. You guys can see my screen okay? So I've been tasked, as Sukin said, of talking about VBT and how that's impacted the indications for selective thoracic fusion. These are my disclosures. Now, when I look at VBT and the impact on STF, the first thing that comes to mind for me is that for the first time, there is another surgical procedure that can be considered, and a selective thoracic fusion is not the only option that's available to our patients. And so this concept of patient autonomy and the shared decision-making model is becoming an increasing focus. This, as many of you know, is our old Hippocratic Oath, and important, surprisingly, there's not a pledge on here about patient autonomy. It wasn't until our more modern Declaration of Geneva that patient autonomy actually made the list. And if you look at it, it's really high up there. So this concept of shared decision-making and autonomy is got to be really important. And I think in the space of VBT and STF and which one is better is really highlighted for me, that discussion. Of course, we'll hear that fusion surgery is a good procedure, but historically, we've really been comparing it to itself. We've got great SRS 22 outcome measures that we keep quoting, but always remember that these are patient reported, but all these questions were surgeon developed. We've actually asked the patients what's important to them, not really recognizing specific questions that might be relevant to them. I think it's not uncommon when you ask patients, they'll say even after a selective thoracic fusion, they can't slouch, they're always upright. Upper back stiffness also are not uncommon complaints. Of course, the fusion surgery, it is a track record, so that's why we considered the gold standard. There's no real upper limit for curve size, anything over 50 degrees, and as you all know, that's because in scoliotically mature patients, they may progress into adulthood, so we use that 50-degree mark. And of course, the cosmetic result is predictable, and it's obtained rather immediately, and Peter showed some nice x-rays with great correction of the curve. But we got to remember why we're operating is not always for correction, it's primarily to prevent progression of the curve. Of course, fusion is fairly invasive. We're exposing instrumenting, we're osteotomizing, we're doing extensive decortication and putting bone graft down so that eventually that becomes one sheet of bone through that area that you're going to go on to fuse, whether it's a selective thoracic, and as Peter's saying, he's cheating lower and lower, so you have to wonder if it's going to remain a selective thoracic fusion or it's going to be more of a lumbar fusion as well. Immediate correction, so in this patient, of course, you can see that radiographically, you can see that clinically as well. And the chance of requiring further surgery is considered rather low, anywhere 5, some reports up to 13% following an instrumented fusion. So, we all feel that a fusion is great because it's one and done with predictable result. Can you return back to activity? Of course you can. Most centers say 6 months, you're off high-level sports. Some centers may extend that to a year, but the point is that you can return. This is a patient of mine who was a previous model for the original Google Pixel phone that came out. She tells me from time to time what she's been doing after a selective thoracic fusion, and 10 years later, she's a firefighter in one of the communities in the interior of British Columbia. So again, you can return. But we have to be honest about motion loss when we are fusing. This is some study. This is some work that we're doing, and also with Michelle Marks and the Setting Scoliosis Straight Foundation. We're looking at patients that have had a fusion as well as VBT and looking at their motion after surgery. And you can see from these radiographs that through that fused segments, your spine is essentially straight and will no longer move. Whereas with a VBT, you still have some normal motion that's maintained, specifically in flexion and extension. Again, Michelle Marks has really blazed the trail in our understanding is when you fuse, what happens to your adjacent segments? And this has some real implications when you extend into the lumbar spine. And we get worried about adjacent segment challenges as you get older, especially on top of a large lever arm of a fusion through even the thoracic spine alone. Motion is important. Many of our patients voice this to us. And so, of course, this has been the impetus for the basic science models that have developed some non-fusion technologies, i.e. the VBT. And as we all know, the first clinical proof of concept paper was then published in 2010. When you kind of compare in terms of selective thoracic fusion versus VBT, a VBT is done through a scope, as we know, so it is less invasive. The correction, of course, is gradual, and because of this, it's a little bit unpredictable. But again, it's not really how straight we're trying to get your spine, but really prevent the progression of your curve. Return to full activities, of course, is a lot sooner. Some centers will be 6 weeks. I think maximum 3 months, anywhere from the 8 to 10 week mark, you can really return back to your full activity. So you can get back a little sooner than a fusion, of course. Now, are we actually preserving growth? So this was a very recently published study that showed that, in fact, the younger patients that have instrumentation, i.e. the VBT, those segments are actually growing on average anywhere from 12 to 18 millimeters over the period of time that these patients were followed, which is about 2 years. So you actually are getting growth through the instrumented segments in a VBT, unlike a tether. And again, are we preserving motion? So again, this is a work that we're still continuing, looking at patients following surgery. And in fact, we are showing that patients with that have undergone a VBT have certainly maintained intravertebral motion segment throughout the length of the spine, which is a little different than a fusion, where you only have motion. And I think it's accelerated in the areas that you are not fused to accommodate for the areas that you are fused. And of course, this really lends itself to some challenges possibly in the future by disc degeneration, adjacent segment disease, and things like that. Unfortunately, the chance of requiring further surgery, as we know, with a VBT is a little high. Original studies have shown anywhere from 26 up to 47% revision surgery following a VBT. I think we're learning a lot that this is really around mostly patient indication in terms of the maturity status, the available growth that's lending to this. Really, the idea is lending itself more to revision surgery has really been around overcorrection and tether failure. So it's beyond proof of concept where the curve is correcting, but it's then correcting too much and swinging the other way. And of course, tether failure, where unfortunately the deformity is just too powerful and the tether breaks. And we can imply this by displaying the screw tulips. And if the deformity continues to progress, then you have the option of either converting to a fusion or a tether replacement, depending on the patient's maturity, of course. Well, what kind of studies do we have out there right now comparing VBT to standard fusion? Well, Peter did this. He was lead author in the harm study group, looked at this, compiled mean follow-up of 2.2 years on a number of patients who both underwent a VBT, and they were matched as those that underwent a PSF. And as we noted earlier with many of the case series studies that are out there, VBT correction is up to about 76%. So not really bad for a first-time item for technology out there. And fusion, again, very powerful because you're doing that immediately, immobilizing the spine. So up to 97% correction of your primary curve. And revision surgery, again, significantly higher, 16%, but again, a lot less than that 16 to 47% that I quoted earlier. And fusion surgery is about 2%. Interestingly, our Turkish colleagues also did a comparative study between VBT and fusion. These patients were matched pretty closely preoperatively. And post-operatively, they actually found almost a completely different results than we did in the earlier study I just presented with Peter Newton being the lead author. They actually found the satisfaction score in the VBT group a lot higher than the fusion group, the trunk endurance to be greater in the VBT group, and also range of motion to be significantly better in the VBT group. So this really study of this comparison between VBT and PSIF showing VBT to be superior to PSIF is really the first study that's reported such findings. Recently at the SRS podium last year, we looked at 328 patients through our harm study group and found that the VBT complications are in fact dropping. It was about 22% in that cohort. And the fusion complications, there were a study presented with 7% revision rates within 10 years. So I think the take home here is that VBT complications are hopefully dropping over time, and fusion complications are not actually benign the longer that we're following our patients. So the decision making, I think if you're looking at VBT, you want to have more discussion with patients around timing, your curve size, your skeletal maturity. I think the candidacy is a really important thing to wrap your mind around. Patients really have to have an appetite for potentially more surgery. Around a fusion, of course, discussion is going to be much more concrete. You've got predictable cosmetic results and potentially a lower risk of a re-op. But in 2023, I would say that VBT is certainly an option that can and in fact should be discussed with patients, provided you give them the right risk-benefit ratio of both procedures. So again, if patients are looking for an immediate cosmetic result, a single surgical event, fusion is probably the way to go. But if they're really keen on motion preservation and earlier return to activity, then a VBT can be considered. I would say, again, just to emphasize that we know that all treatments are really aimed at preventing our curve progression. Curve correction, of course, can be offered by surgery, but that's not the primary goal. And so a selective thoracic fusion, I don't think is the sole surgical option for patients with idiopathic scoliosis. And I think our landscape has really evolved to really make it more a shared decision-making model. And for me, an STF indication is really drifting to larger, stiffer curves in skeletally mature patients, where I think the VBT certainly is not indicated. And you can certainly push the limits for selective thoracic, even in something like this, that would be considered a lanky 1C with a structural lumbar. If you do a front and back, you can probably get a decent correction. But I think in a smaller, flexible curve with growth potential, VBT is certainly a viable option. And so this has been my practice over the past 10 years. Of course, early on, VBT was not as common, but over the years, learning with indications and the right selection, it's become more common. I'd say right now, I've probably settled between a 70-30 mix, where 70% of my patients are fusions and 30% are VBT patients. Thank you very much.
Thank you, Firoz. That was obviously a very nice summary, sharing your experience as well. And thank you for obviously all the research you've been contributing and advancing understanding. Just a reminder, if anybody has any questions, please type them out in the Q&A section and we'll forward them just to get us started. I mean, you kind of alluded and kind of touched on it a little bit, Firoz. What key factors might sway you towards a fusion or towards a VBT if a patient is really indifferent at this time? Are they radiographic findings that push you one way or the other?
Yeah, great question, Steve. I mean, because of the limited amount of time, it's hard to talk about all planes, but I think sagittal plane is one that we really need to focus on. And I think if somebody really has a significant amount of lordosis, I mean, most of our patients are going to be lordotic, but if they've got a lot of lordosis in the thoracic spine, I think you'll correct that better. And Peter showed some nice examples with a selective thoracic fusion. So I'd probably point them towards a fusion rather than a VBT. I don't think that even if it's an anterior-based procedure, we're trying to modulate the growth from the front. I just don't think they've grown posteriorly enough to recreate that appropriate sagittal plane. So I do think the sagittal plane is an important element that VBT is still limited in restoring kyphosis.
Absolutely, thank you. And what obviously you have experience with both, so you have tons of experience both the VBT and the fusion. A lot of surgeons may not, be just on the early learning curve of VBT. What you have a couple lessons and pointers you might share in terms of key things to avoid?
Yeah, I think Peter alluded to level selection and selective thoracic fusion. It's funny, almost like 40 years later, we're still debating, where we stop end vertebrae stable. Do we now go from end vertebrae +1, what's neutral, et cetera? VBT is much of the same. We've kind of extrapolated from our anterior fusion literature and our experience to go from end vertebrae to end vertebrae. And I would say that you really want to respect that. I don't think you want to cheat short, especially above. I think sometimes getting that T4 screw may be technically a little more challenging. And in doing so, people might stop short. The other area is that lanky 1AR curve. We learned later as well with posterior fusions that the lanky 1AR curve, we need to go a little lower. And I think in VBT, we need to do that as well. So don't be shy of going a little longer proximally or lower, going end to end. It's a 1AR. You probably want to go to the last touched vertebrae when you're looking at that. So I think level selection is probably key. And then I think you really want to get a better and a more accurate understanding of growth. Look at all the markers, anarchy, wrists, or Sanders, patients height in relation to their parents, et cetera. So I think we use all that to really determine whether there's going to be enough growth for you to have this offering to patients to make it successful.
Great. Thank you, Firoz. But maybe we'll try to squeeze one more question in terms of the VBT. So a couple just popped up. So what's your ideal first case to start for beginners, somebody without experience?
So definitely a Lunky 1.8L. I would look at a curve anywhere from 40, probably about 50, 55, nice and flexible, bends down to less than 30. Sanders, ideally an early 3, like a Sanders 3A would be, I think for me, those parameters would be. And of course, highlight to the patients that, if you're looking for a completely straight spine, then VBT is not for you, and they've got to be, they've got to be open to that. But motion preservation, if that's important, then I think, yeah, that's what I would consider. So that would be my ideal first case for sure.
Great, thank you, Firoz. We might try to have Firoz answer some of these Q&As and type them in as just to preserve time. So next we'll move on. I have the honor of presenting my partner, boss, Amer Samdani. So I think Amer's trying to share his screen, but he's going to talk about kind of where VBT and fusions kind of blend hybrid techniques. Take it away, Amer.
Great. Thank you, Steve. You guys can see my screen okay? Excellent. Well, those are two fantastic talks. And I think in this talk, what we're really been trying to do, Steve, myself, my partner Josh, is really trying to pick the best of both the thoracic fusion and of a VBT motion preservation in this hybrid procedure. And here are my disclosures. I do receive royalties on the ZimV tether product. So what are our current indications for VBT? And essentially, there's just two main categories. It's going to be skeletal immaturity, although depending on the patient, we can go up to a Sanders 5 or maybe even a Sanders 6, depending on what that patient looks like, where the curvature is. And then, of course, the curvature itself. It has to be a curve that has some flexibility to it, ideally bending less than 30 degrees. But what we have to recognize is what our indications are may not be really what we feel are optimal indications. There's general indications and there's optimal indications. And in this talk, I'll kind of take us through how our thinking with VBT has evolved, because what you see in front of you are three separate patients. That patient with that right thoracic curvature, next one with that thoracolumbar curvature, and the last patient with the double major curvature. And I'd say that we approach all three of those patients in a very different manner, even if they were to meet our indications, because they may not optimally meet our indications, because we have to balance with VBT, the motion preservation, perhaps later in life, less degeneration, with absolutely less correction and more reoperations. As Firoz stated, the complications are decreasing with VBT, no doubt about it, as we learn and optimize our indications and our technique, but they're probably not going to get to that 2, 3, 4, 5% that we see with posterior spinal fusion. This idea of complications has been well spoken about. Firoz already spoke about his series, 300, the Harm Study Group series that he presented at SRS. 328 patients, 22% complication rate, 8% went on to PSF. And then Ron Halawari and Abdullah et al. Presented the PSSG data set, 120 patients, 16% complication rate, 7% unplanned return to the operating room. So putting that in perspective, when you have a patient with a thoracic curvature, and they will certainly have less motion with the posterior spinal fusion, but it may not be clinically significant for most patients. Perhaps for that patient, when we see that child, we'd say for most of those kids, not all of the kids, the reliability of a PSF is probably the right answer. But contrast that with patients that have thoracic curvatures that actually extend lower down into the lumbar spine. So that overhang curve that goes down to L1 or L2 for a fusion, I'm much more apt to consider doing tethering in that patient. Because we know that those patients, if we let them go, they may continue to progress and go lower down into their lumbar spine. If you are going to do this, you do have to make sure that you go distal enough. Early on, we made two mistakes. Number one, we would short our tether, and we wouldn't really go to the last touched vertebrae, and they would add on. And secondly, we didn't leave enough slack in that distal level. A lot of these patients are flexible and they will overcorrect in the spine. What you're seeing in your right-hand corner is a video of how we go about leaving some slack in that tether. We will put our set screw on and then tighten it after we have turned it into the sagittal plane, leaving a loop in. So it's really important for those 1AR curves to go distal, because those patients are at risk for adding on. 31 AR curves, 47% had some degree of adding on. But if you went ahead and went distal down to the last substantially touched vertebrae, that adding on did decrease. And we've put this together in a little paper that we've submitted. Now, as much as thoracic fusion works well for most patients, I feel equally or even more strongly about avoiding lumbar fusion. And this is where we have been pushing the limits. Of course, the trick is, how can we drive more patients to the outcome that we have here? Is it our surgical technique? Is it, optimizing when we intervene? It's likely going to be a combination of that, but I can tell you, we have certainly been pushing the limits on this front. So here's a child who's 3 years out, 15 years old, had these two curvatures, but she also had a high grade, she had a moderately slipped L5 over S1 as well, asymptomatic from her slippage. And so for this child, Sanders 6, but we did end up pushing the limits, and she's about 3 years out now, and we ended up doing a tether. Can this tether break? Of course it can break. It will likely break, but will it ever go back to surgical range? Can't be 100% sure, but I feel as time goes on, it's unlikely. It may break, you may lose 5-10 degrees of correction, but she will in all likelihood avoid a fusion in the lumbar spine. So we spoke about thoracic curves and lumbar curves. What about that patient that's got that double major curve? This 12-year-old child, Risser 0, Sanders 3, has got a 63-degree lumbar curve, 55-degree thoracic curvature. For this child, we can certainly look at all of our different options. We can do a fusion. You could consider doing fusing both curves. Perhaps you could do a selective thoracic fusion, but unlikely. That lumbar curve is larger. And you could certainly consider tethering. Tethering for this curvature for us would certainly be tethering both curvatures. I just don't think you're going to get a good enough result if you did a selective thoracic tether for sure on this patient. Well, if you fuse both curves, radiographically, the outcomes look great. Nick Fletcher recently published from the Harm Study Group in 2022, 54 patients with Lenke 5 curvatures. There were actually no re-ops in that particular cohort. Paul Sponseller more recently presented for major lumbar curvatures, a reoperation rate between 5 to 7%. So there are reoperations with major lumbar fusions, without a doubt. And any takers for a thoracic only fusion, certainly if you wanted to take a chance, you could consider that. But of course, we'd be at a high risk for decompensation, as you see here. What about tethering both curvatures? And there are papers out there that would suggest you can get reasonable results. This was a paper out of Turkey, small cohort, 13 skeletally immature patients. You can see pre-op Cobb angles of 48 and 45 degrees thoracic and lumbar respectively. And in their cohort, they did not have any neurologic, any implant-related complications. That's really not been our experience. I would say some double curvatures are going to do well and have very sustainable, reasonable results. But there's going to be a subset, and we're just looking at our double major curvatures, somewhere around 30% are not going to have an acceptable result, as you see here. They may look okay in the beginning and then end up with tether breakages. So I don't think that that's really the best option. So if you're trying to decide between these two, I'd say that we can do this hybrid procedure where we can focus in on doing a thoracic fusion, trying our best to recreate the sagittal profile. And what we like to do is 2 days later, come back and do a lumbar tether. And that's what we did for this child, and here she is. In this hybrid approach is where we've been pushing the limits as well. Here's a child who was actually a Sanders 7. So she had a 59-degree lumbar curvature. She's 2 years out now, 53-degree thoracic curvature. And for this child, we did a thoracic fusion and a lumbar tether. Time will tell what that lumbar tether will do. I know it's still relatively early, but my suspicion is that the thoracic fusion to some extent is going to be protective for that lumbar tether. Obviously, we're very concerned about tether breakages. We hear it at all of our national meetings. Tethers are breaking. You know, in our cohort, Steve Wang just published this in spine, 32% breakage rate and very high in the lumbar spine. But please note that the vast majority of these breakages are going to be asymptomatic, but there are some that may end up progressing. So what we've been doing to help protect against this, we've been using a double row of screws. This may give us some additional time to modulate. I do feel the correction is more reliable, but they can still break in the lumbar spine, even with 2 rows. So what does the data look like? We've done actually over 35 patients now. We have submitted this, our first 20 patients. You can see the vast majority of them have primary or have major lumbar curvatures. You can see the 6 Cs and the 4 Cs, and they are skeletally immature. These are big curves, thoracic of 67, lumbar of 65. If you look at the 3D kyphosis, a lot of these patients in the thoracic spine are hypokyphotic. And we have overall been very happy. We have not, at least to date, had a revision on this. We have over 2 years of follow-up, but we'll have to see what these kids look like at 3, 4, 5 years down the line, but certainly encouraging what we've been seeing now. So what has our early experience been? I'd say that this procedure is best for major lumbar curvatures. 1 Cs still, I think a selective thoracic fusion will work the vast majority of the time. With respect to level selection, we like to still pick the thoracic fusion as we would do a selective thoracic fusion is what we like to do, and then go ahead and follow that up with a lumbar tether into the lumbar spine, oftentimes to L4, even if we leave L3 and L4 loose. You still have to be very wary. Here's a kid I had about 3 months ago, and you can see that I tried to leave that distal level between 11 and 12 loose, but have to be very cognizant because those areas in the lower thoracic spine and lumbar spine tend to grow more, and they're still at risk for overcorrection. So in summary, we are doing fewer thoracic tethers, although I love that 1AR curve pattern. I think we're pushing the limits on lumbar tethers, and we'll continue to look at our data to see how those patients are doing. And then this hybrid procedure has really been very nice for us in the patients that would have had a fusion to L3 or L4. And I'll stop there, Steve.
Thank you, Amer. Obviously, thank you for being a key pioneer in the BBT and helping us push things forward. As we wait for some questions, so obviously this hybrid is brand new, it's pretty exciting. Is there a lumbar curve you feel is too large? Would be the upper limit of what you would find acceptable to try to do a hybrid, or the flexibility, or is there a factor that would make you shy away from that?
Steve, I'd say absolutely. If it's rigid and it's not bending under 40 degrees, I'm still very hesitant in that patient. I know you've done a beautiful job on one patient that has stiffer lumbar curvature, but I still think that you have to be careful with that patient. The vast majority of the curves are going to be flexible enough to do that lumbar tether, but I'd say if they're not bending under 40, I still get nervous.
Thank you. And how do you choose your levels? Obviously, things are different. We heard from Peter about level selection for a selective thoracic fusion, going a little bit longer. And you mentioned a little bit how that gives them a little more comfort, potentially going below and doing a tether in the lumbar spine. How do you choose where to do LIV for the fusion part?
Yeah, so, obviously Peter showed some beautiful results, and I think they're going to be sustainable. But the way that I see it is I'm fusing the thoracic spine to give the lumbar spine the best chance to correct. And hence, I really try to choose our selective thoracic fusion principles. I'm not going as close to the apex. One theoretical concern I have is as you get closer to the apex, and then when you have that tether, will that tether be more apt to break because you're right at that apex and you've got a rigid spine above it? Again, that's a theoretical concern, but something that's driven me more towards just using STF principles for the selective thoracic fusion.
And along those lines, so when you do the thoracic fusion part, are you, like you said, trying to make it protect the lumbar spine? You're trying to level the LIV, and Peter's published a little bit about how to get more correction in that lumbar curve. You try to level the LIV, get more derotation with the thoracic spine and more coronal correction? you try to maximize all those. And
Yeah, and you know, Peter touched on it. I really think it's that sagittal profile. Really trying to spend as much time as possible to pull it out. A lot of these kids are very hypophotic and really trying to pull out that that thoracic. For me, that's really the primary. Of course, all the other things, derotating, counter derotating below the neutral vertebra, maximizing correction is something that we push for, but really in that sagittal plane, trying our best to pull it out.
great. So I think we'll move on to some cases and get our panelists to discuss. Let me just share my screen. I have to start. Go. So I'll start off with a couple of cases. The rest of the time, if I get through as much as we can. This is a case that thank you for contributing, donating. So this is an adolescent with thoracic 49-degree curve, lumbar 38. We have the PA and the lateral views here. Maybe Peter, could you tell us how would you approach this or manage this?
Yeah, well, it looks like a fairly, I suspect that lumbar curve is very flexible, given the patient looks immature, and most 38-degree curves are quite flexible. So I think this would be a candidate for selective thoracic fusion or vertebral body tether. I like a B curve more than a C curve for the tether, to be honest with you. I just think it's a little bit more reliable. So I would probably be leaning towards selective thoracic fusion for this patient. And the patient is decompensated to the left. I know that makes some people nervous because that's what happens to selective thoracic fusion patients post-op is they go left. And if you already start left, how far left can you go? But it turns out that tends not to be a real contraindication as long as you don't use the stable vertebra as your landmark here, because you can see how proximal it is. It's nearly at the middle of the thoracic curve. So you've got to go use the end vertebra, and in this case, a neutral vertebra. And again, I'd be going one beyond neutral. So certainly 12, and 12 is probably a reasonable number as long as the sagittal stable vertebra is consistent with 12. We don't really have that line, but so I'd be thinking of selective thoracic fusion to 12 if I had to kind of just shoot from the hip here.
Great. And I think that's pretty similar to what Sukin did. We'll go through some of these initial post-ops. And you touched earlier on derotation technique and kyphosis. Are there any tricks otherwise to really create that kyphosis and get that 3D correction?
No, I think I touched on it. You know, it says posterior column release, rod contour, rod diameter, rod material. And I mean, again, I'm happy if you want to use a different rod material. You just have to put your rod contour to be appropriate for the material that you use. And at least for me, the derotation technique, I want that screw at every level in the bottom because I really want 2 screws to derotate on. So I want to rotate around T11. I want to rotate 12 around T11 one direction. I want to rotate 10 around T11 the other direction. And so I want both of those screws to do that derotation. But other than that, I'm and you can see this came around beautifully. It was a little off to the left at 1 month. That's not uncommon. You got to counsel everybody. That's what's going to happen. And then hopefully you get to have this result by, 3-6 months. It's back to midline and beautifully balanced. Do we have the laterals as well?
Yep. So these are the lateral views.
Yeah, beautiful. I mean, there's a little hint that it almost wants to look distal junctional kyphosis at risk in that 1 month post-op. And again, I don't know if we quite got to sagittal stable on this one, but that has also come around really nicely with time. So that kyphosis created allows that lumbar spine to take on a lordotic position that matches the pelvic and says, this looks perfect to me.
Yeah, Peter,
Great
if we could
results,
just spend a second talking about that. The ones that do seem to currently decompensate and have the DJK worry me earlier. And so I have to confess, I had a little bit of anxiety early, but we have to be patient with the parents and the patients too. And I think if we give them the expectation that some left-sided decompensation with the left shoulder up is what we expect to happen early, but should continue to improve, I think they're able to palate that a little bit better because frankly, she looks worse post-op than she did pre-op for
Yeah.
several weeks. And then
Yeah.
things settle down.
I think that's true, but you also, look genius if you can predict it and then I told you it was going to look like this, right? Yeah, I did. And it looks just like it. And you gotta wait. And when it comes back around, you go, wow, you said it was going to come back. I'm really glad it did. The problem is when it doesn't come back around and you're left with them to the left forever. Fortunately, I don't think that's that it's a risk. I think when you do this operation, I don't think we have every bit of understanding on all the three-dimensional nature of scoliosis. And again, if you treat the sagittal and go one longer and you get closer to the apex, what's that do if you don't really derotate it well? So there's a lot of nuance to it, unfortunately. And the safest is to undercorrect everything and leave two curves that are well balanced, but I don't think that's good for the long term. So as you start out in this, I think you just keep trying to push it harder and harder and harder until you finally kind of find the limit of what works in your hands.
So Peter, do you feel like since you have to derotate and obviously all these every level matters, do you think the implant density is important to kind of maximize that?
I don't know how important it is, but I know that I don't like derotating on a single screw. I don't like that concept at all. I think it's dangerous to twist that screw in or out of the bone. So I think sharing the load, at least with the amount of force that I apply, I want two screws at those levels. So yeah, that drives me to a high density construct. Is that absolutely required to make this result? I mean, obviously it's not, because this is beautiful and it's missing two screws. How many could you skip? I don't know. I really don't. But I still remain high density because I pretty much do some work with every pair of screws that I put in.
Great. Thank you. Thank you, Sukin, for sharing that as well. We'll move on to the second case. I don't think there's any questions that came up. Amer, there may be a question for you on the chat as well. This was 11-year-old girl, Sanders 5. Sorry, I was blocking my screen, but Sanders 5, thoracic 52-degree curve, kind of bent down to about 30 degrees. Lumbar was a little bit bigger at 55, so technically a 6, but that was a little more flexible, bending to 12. So Amer, I'll toss this to you. How would you manage this, and how would you approach this?
So again, Steve, this is an 11-year-old Sanders 5, post-menarche, I take it?
Yeah, I forget exactly. I think she was 6 months, maybe 9 months.
Yeah. So thoracic curve, lumbar is a little bigger, certainly appears to be bigger here, although they both have reasonable flexibility. So for me here, this is a great indication for a hybrid technique for me. I do a thoracic, selective thoracic fusion, follow that up with a lumbar tether.
Yeah, probably have been biased because I work in some place you do, so I was a little biased. We did approach it that way. So this is the initial on table X-ray. We tried to get as corrected with the idea that maybe we're going to tether the thoracolumbar spine to bring that left shoulder over. I don't know if Amer, do you similarly on the table, do you have goals of trying to get it straight? Do you worry that the left shoulder is high, if the right shoulder is high, does that worry you more?
Steve, what I like what you've done in that sagittal profile. You've really recreated, kyphosis there, and really just try my best to maximize correction on the table for the selective thoracic fusions. Knowing full well that once you get more correction off that lumbar curvature, that's going to help with your overall shoulder and overall balance.
So this was her just first erect, she's still splinting, and then we took her back into the lumbar VBT on the left side. We did double across the apex. I didn't double across the LIV. I don't know, do you, Amer, typically double up the VBT side of the apex at the LIV as well?
Typically the vertebrae that are just distal to your LIV and your most distal tether LIV are going to be very flexible. So I've just been doubling up right across the apex, much like you did here, Steve. Others, Amit Alanay and Amit, I know does double all the way up and down, but I've just been doubling much like you did there, right across the apex.
One of the concerns, Amer, you sort of raised earlier as well, and I know that others have suggested is that junction between the fusion and the tether may put that tether at increased risk. I mean, you commented on it. If I go towards the apex, it's more at the apex might be greater risk. But I think no matter where you start that long fusion and then start your tether, I would at least say, could we at least have a double at that junction too?
Yeah, I mean, it's just the real estate gets a little tight in there. With
Yeah,
those
sure does. You got two
those
screws
two-
from the back and two screws from the side. I've remained a single single cord lumbar person for most of these hybrids, in most cases, but it's interesting to kind of see the evolution of how many tethers and how many cords and how many screws.
Peter, I've seen a couple of
93.
hybrids have a little bit of DJK, and I wonder if the tether's compressing at that level, or it's just my technique might be kind of poor. Have you seen that, or do you know, how do you avoid that, that transitional level?
Yeah, that's a great question, Steve. I do think that if you go a little shorter and you're compressing, perhaps you're putting yourself at risk for that. I don't know the clinical significance. I haven't seen that area progress, but that is something that you have to balance. I bet if you go a little bit longer, you'd probably be less apt to have that. No doubt about it.
Yeah, I think that's right. I mean, that's true whether you do a selective thoracic fusion. I mean, that's the whole idea of if you're not getting to sagittal stable, you're going to have a DJK risk. And I mean, if you go a level longer, you've got just one less level you've got to worry about the tether breaking.
Amer, we've got a question from Rob in the chat about the effect of the VBT on lumbar lordosis here. So can you tell us a little bit about mechanics of correction, on table techniques, trying to avoid direct compression along the convexity, which would in turn decrease lordosis? How do you handle that?
Yeah, so, this was a real concern of ours. I remember back in 2014, 15, I mean, we actually started with thoracic tethers first and then went into the lumbar spine because we don't want to create iatrogenic kyphosis. And I remember Tom Errico all the time would say, hey, you got to be careful. But what really helped me was when Peter started doing his 3D work and started showing just how lordotic these lumbar curves actually are. When you spin them out, they are really overgrown in the front. And I would say that if you keep your screws on the posterior half of the body, at least that primary tether, that's one technique that we use to try to prevent iatrogenic kyphosis. Certainly adding that second tether, you're absolutely right. If you truly are compressing beyond what you've compressed in that posterior tether, which we don't do, we essentially just lay it in and just get the slack out, you could put yourself at risk. And in our three-dimensional studies, I just haven't seen it. I was looking for it because, believe it or not, with vertebral body staples, I did see some excessive kyphosis with staples, and I saw more bony overgrowth with staples. So early on, I was very cognizant. I just haven't seen it. So in some ways, it's helpful because in the lumbar spine, it doesn't create iatrogenic kyphosis. But on the flip side, in the thoracic spine, boy, if you're hypokyphotic, it's not going to give you as much kyphosis as you're hoping for.
And there are a couple of questions on the staging scheme. Why not do it in one day? And John's got a question, is it purposeful to do it on 2 days separation so you can stand the patient up and get an x-ray and a clinical exam? So
yeah,
tell us about that.
Absolutely. You can definitely do it in a single day. Just the logistics of the way things work at our hospital, getting our general surgeons and other logistics. And quite honestly, the lumbar tether for us now runs into the early afternoon, especially when we're doing that second tether. So I think it's perfectly okay to stage these. But if you have the right setup, you can absolutely bang these out. When we did double tethers, we would do them in a single day, but the selective thoracic with the lumbar tether, more of a logistic question. I think gives the patients a chance to recover, and that's the way we've been doing the vast majority. Just staging them Monday, Wednesday, or Tuesday, Thursday, something along those lines. I don't really give too much credence to standing up early on. I think you guys have mentioned already that it takes their splinting, and it's hard to really tell where they're going to end up. So pretty much have made that decision preoperatively that we're going to go ahead and proceed, at least in the short term. Now, that being said, the 1C curve pattern, we will wait. If there's enough growth left, we'll see how the patient does and then decide if a lumbar tether is needed.
Well, we already talked about how they're always going to be decompensated to the left. So Peter, that means a tether in every one then, right?
I hope not. I sure hope not. No, I think that's one of the risks of this hybrid, to be quite frank with you, is that every 1C curve that would do perfectly fine with a selective thoracic fusion, folks start slamming in a lumbar tether when it's not needed. So I agree with Amer. You saw his indications. The vast majority were 6C curves, 11 of them out of the group. And so if you've got a lumbar curve bigger than the thoracic, this is a way to save the lumbar spine if they've got enough growth. And I think it's really one of the real benefits of tether today. And I'm not a huge fan of doing 5Cs alone, but I'm a big fan of doing 6Cs in kids that are growing. I think it's really powerful.
I think we may be running at the end of the session. So I just want to thank all our panelists, all the expertise, and I always learn something on these. It's great. That's unparalleled. And thank you all the attendees as well for participating and great questions. If anything else comes up, please feel free to email any of us. I'm sure happy to answer more questions. Thank you all.
And we've got,
Everyone.
you can point your phone to this QR code to donate now. These webinars, educational efforts, and all of the data presented in this webinar, frankly, costs a lot of money. And we need your support. If you'd enjoyed this program and want to support the Setting Scoliosis Straight Foundation, please donate now. Thanks very much.
Great job.